Assalamu alaikum. This is a video regarding the left-sided Anderson-Hyne pyeloplasty. I have mobilized the colon and everything, and here you can see that the patient is thin. This is the difference between the gonadal vein and the mesenteric vein. Some people take it for a gonadal vein and they dissect and they end up somewhere else. Here you can see the arrangement of this is the gonadal vein, the arrangement of ureter with the gonadal vein here. The peristalsis of the ureter can be seen. So what we are suspecting, you can see through the tissue that there are lower pole crossing vessels which are causing the primary PUJ obstruction. So the goal here is to dissect the pelvis from above and the ureter from below, so that the ureter can then be dismembered from the renal pelvis, and a re-anastomosis is performed anterior to the vessels. Careful here, because if you are dissecting the pelvis first method, there is a chance of injuring the renal crossing vessels. That's why a preferable method is to dissect from below upwards along the ureter in such cases. So when I reach this point, I usually prefer the monopolar hook, because monopolar hook is a precise coagulating instrument, and it can really give a good field, a bloodless field. So monopolar hook is a very good thing here. So the principle here, this is the ureter, you can see the PUJ, sorry. The principle here is that you dissect the ureter from the vessels rather than dissecting the vessels from the ureter. There are small vessels. The artery is also a very small one, but a major chunk supplying the kidney. But the vein is a delicate structure. If that gets injured, things become messy, and then you have to do something else rather than pyeloplasty. So what we are doing here is that I'm dissecting all the peripelvic connective tissue, so that good mobilization of the pelvis is achieved first for the resection and then for re-anastomosis. So here you can see all the sheath layers have been removed from the pelvis, and the pelvis is exposed. So dissecting in this plane also has an advantage, that the injury to the vessels is minimized, because when you are dissecting away this tissue from the pelvis, the vessels are automatically dissected away. And the principle of using the hook is that when you are applying the diathermy, tissue must be so minimum that the hook should be visible behind the tissue. If you are taking the tissue for coagulation and cutting by a monopolar hook, and you cannot see the hook through the tissue, it means the tissue is too thick, and this thick tissue may not be coagulated just because of the volume of the tissue, and there must be, or maybe, some important structure in that thick tissue. So you can see that I'm using the hook in such a manner that only small amount of tissue is taken, and I can see the hook through the tissue. So we are dissecting this pelvis. You can see that the pelvi-ureteric junction is quite high rather than low. So the main obstructing element is the crossing vessels compressing upon upon the ureter, especially in cases of increased diuresis. When the pelvis gets distended, it pushes itself against the crossing vessels, which can lead to even further obstruction. Since the pelvis is extra-renal in this case, the patient is lucky. The function of the kidney is okay. So I'm mobilizing some more of the tissue along the ureter so that the ureter is mobilized. It is not really very necessary to mobilize the whole ureter, because that would compromise the blood supply to the ureter. However, you can see I'm mobilizing it while the periureteral sheath is intact, and you can see the longitudinal vessels on the ureter very clearly. So the ureter from above the vessels is now properly mobilized. We have not even touched the vessels, so all the tissue is mobilized. We can see that there is a window, and you can see the artery and the vein clearly. So the next thing, and now you look at it from below, you can see that enough ureter is mobilized behind the vessels. So I'm marking this area so that I know where to cut and then which side to spatulate on the ureter. We usually spatulate the lateral aspect. So here the ureter and the pelvis are disconnected, and you cannot see a lot of urine draining from the renal pelvis, which means that there might be some intrinsic factor as well contributing to the pelviureteric junction obstruction. So then after doing that, we will pull this ureter below the vessels, and then you can see that I am using the monopolar scissor very much away from the ureter itself to get it a little more mobilized in order to be anastomosed to the pelvis. So not more than that should be mobilized, because that will compromise the vascularity. And now spatulation. The kidney, the scissor is engaged into the ureter and then slided rather than cutting. So this will give you a smooth edge of the ureter. And this portion of the pelvis is really very important, connecting to the lower calyx. This one you can see. So we should not cut it here. We should cut it here so that you can see that urine is coming out. So the intrinsic factor has been addressed in this procedure, as well as we have adequate tissue of the pelvis attached to the lower calyx, and then we cut both the flaps of the renal pelvis. Too much excision is not advised and is not even required. Now we take a stitch outside in, keeping in mind not to take the posterior wall or the anterior wall of the ureter, the opposite wall. And then we do a surgeon's knot. The first knot should always be surgeon's knot so that it doesn't slip away. You can see that the ureter is beautifully and nicely pink, ensuring its intact blood supply. And the pelvis and the ureter are anastomosed to each other without tension. And this has been facilitated by the step that we took not to cut the area of the pelvis which is adjacent to the lower pole. That has facilitated that, because the pelvis can now come down. And then we bring the suture to the posterior aspect, and then we take it from the inside. Here you saw the alignment of the needle. One method of alignment of the needle is that you place the needle on a tissue and then you bring this is the second method. Let's discuss this first, and then we'll discuss that one. Hang the needle by the thread with the left-handed instrument, and then you grab it with the needle holder. It will automatically be aligned. So this was the second. This is the third method. You hold it like this, and then you rotate it with a needle holder, and hence it will be aligned. Needle alignment is extremely important for proper suturing. That is because it is a two-dimensional view, so alignment of the needle is difficult, and if the needle is not aligned, you won't be able to take any sutures. So practice these three methods on a laparoscopy box in the trainer. So the first method is that you place the needle on the tissue, and then you bring in your needle holder, and the posterior jaw of the needle holder is behind the needle, and then you close the needle holder jaws half, not completely. In this half closed needle holder, then you push the needle with the anterior jaw of the needle holder. This will make the needle stand up, and then you quickly lock the needle holder, and thus the needle will be aligned. And you saw the second method, that hang it about 3 centimeter from the needle by the thread, and then you grab it with the needle holder. And the third one is that you grab the tip of the needle with the left hand instrument, and then you can rotate the needle with the needle holder to a position where it becomes aligned. So you can see that it is a watertight continuous suturing with 4-0 vicryl. Care must be taken that the suture line does not get loose. So for that, one has to stack the suture every time. So once you reach the half of this flap, you take the needle outside, and the suture is outside and loop is created. You take another stitch, and then you stitch it with the loop. So here now we'll be doing the anterior wall. So bring that first suture anteriorly. That will make the anterior corner of the tissue right in front of you, and then I usually take one stitch. These sutures can be continuous sutures, they can be interrupted suture. It is a surgeon's preference, whatever he or she wants to do, but it has to be watertight. So we take the first stitch, we secure it by knotting it twice and thrice and 4 times, and then we cut the tails, just because if these tails are not cut, they are going to create problems during our stitching. And then I use my 2 millimeter alligator forceps needle for stenting. Stenting can be antegrade, it can be retrograde later on, but antegrade is the best. You make the tip of the guide wire in line with the length of the ureter, and then you grab the guide wire and the stent, and once the guide wire is in the mid ureter and distal ureter, then the procedure becomes easy. But it has to be, the stent has to be in line with the length of the ureter. Only then you will be able to place the stent, otherwise there is going to be a lot of struggle. So you push it as much in as possible, and then you remove the guide or the glide wire, so the stent will make a loop. Since this is a single loop stent, that's why I left the loop outside. Otherwise, if it is a double loop, I will push the stent much more into the urinary bladder so that the coil becomes straight, and then I take this coil tip of straightened coil tip of the stent into the upper calyx and release it there, so that it makes coil inside the pelvic ileal system or the upper calyx, and it will not hinder us while taking the further sutures uh, of the anterior wall anastomosis. Care must be taken not to take the stent in the stitch, whether that is a laparoscopic or open procedure, because that can lead to severe trouble later on. So this is it. We have adequately dissected the ureter below the vessels and then above the vessels, and the vessels are conserved. And then we dismembered the ureter from the pelvis, and then we excised the diseased portion of the PUJ, and then we started anastomosis, posterior wall, and then a stitch in the anterior wall, then placed the DJ stent, and then we did the anterior wall. Once we reach the corner, it is easy to anastomose. The rest you can do it from below, you can do it from above. Once this part of the anastomosis is done, we can grab the excised portion of the pelvis just for a retraction, so that anastomosis is done easily and away from the DJ stent. Or here you can see that I'm using that 2 millimeter port for grabbing this portion. Some surgeons would suggest suspension of this portion of the pelvis to the anterior abdominal wall. Whatever is easy for you, you can follow that. So this makes life easy. There is no fear of taking DJ stent into the stitches. And once we reach that area, we cut it, and I usually start suturing the remaining of the pelvis from above, because it is easy for me to suture this area from above downwards rather from below upwards. So we have completed the anastomosis. So now we will place a drain 20 to 22 FR, and the drain will remain in the pelvis rather than in the renal area, because it's a transperitoneal procedure. If there is any leak, it will go to the pelvis. It will be easy to drain it from there. So the drain is removed on the first post-op day if it is not draining much, or more likely on the second post-op day. However, the catheter has to remain there for a week to 10 days. I usually prefer 10 days, giving enough time for the anastomosis to get sealed. And once we are done with this procedure, I will show you the results. Here you can see there is no tension on the anastomosis. The anastomosis is wide, funnel shaped, watertight, and you can see well vascularized ureter in anastomotic area. This is the vein and artery which are gone behind. Thank you very much for watching.